have three eminent speakers: Dr. Fawaz Amin from Doha, Qatar, Dr. Sharif Omar from New York, United States, and Professor Dr. Azhar Musa from Middle Furat, Iraq. We will have three focused lectures and 4 credit hours for attendees. In addition to certificate of attendance from Leptos, a recorded webinar, and currently live streaming webinar on both Facebook and YouTube. We will start with the welcome notes of Dr. Sharif Omar. Then Dr. Fawaz will talk about the management of infertile couple, followed by presentation on of Afro-Fem rule in female sexual dysfunction, female infertility, and the couple therapy. And the last presentation by Professor Dr. Azhar about special infertility management. Then we will have a closed session for questions and answer, ended by closing remarks and certification. Just some key hints before we start. The mic is muted for all participants, and question and answer will be by the end of all lectures. And please use the question and answer window to post your question. And also we would advise to direct your question to which one of the speakers you would like to ask your question. If you get disconnected, please use the same link to rejoin, and the recording will be available for future review. And also, if you request any publication or references, will be shared with you upon request. So it's our pleasure to introduce Dr. Sharif Omar and welcome our Vice President of Leptos Pharmaceuticals. He is joining us from United States. And the first talk for Dr. Omar is a welcome notes. So welcome, Dr. Omar.
So good evening, everyone, and a very warm welcome to the Leptos Pharmaceuticals webinar. Before we start, I would just like to say that I hope everyone is safe and healthy during these pandemic times. We know how everything has been turned upside down with the COVID-19 pandemic, and we stand united with you in doing everything we can to continue to support you in your medical practice. To that end, we have adapted our communication medium to continue to bring you the continuing medical education that you rely on to continue your practice. And we're honored today to have 2 eminent speakers, Dr. Fawaz and Professor Azhar, who will be sharing with us their expertise and their insights. And I wanted to thank each of them personally for accepting our invitation to join our webinar and share with us their expertise. We look forward to a very informative and focused session from their presentations. I won't spend too much time with the introduction because we want to get started with our session. We hope that everyone finds it fruitful and informative and supports you in your practice. Bear in mind that Leptos stands united with you, and we will continue to work closely with all of our partners as we get through this phase. So thank you once again for joining our webinar, and I'll see you at the next presentation.
Dr. Fawaz Amin Saad, our first speaker is Dr. Fawaz is a senior consultant OB/GYN, Faculty of Medicine, Tishreen University. Also, he is the general manager of Al-Hayat Medical Center in Doha, Qatar. And also, he is Arab board member of OB/GYN in Arab. Dr. Fawaz's topic is management of infertile couple. So welcome, Dr. Fawaz. Please share your slides.
Good evening. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ahmed. Thank you, Dr. Sharif. And good evening, everybody. Our topic today is the management of infertile couple. And our agenda is to the definition of infertility, causes and risk factor for infertility in male and female, and also management of infertile couple. Infertility is a common condition with important psychologic, economic, demographic, and medical implications. It is a unique medical condition because it involves a couple rather than a single individual. Infertility is defined as inability of a couple to conceive after 12 months of regular intercourse without the use of contraceptive in women less than 35 years of age. After 6 months of regular intercourse if the woman is more than 35 years or older. Fecundability is the probability of achieving a pregnancy in one menstrual cycle. Usually, fecundability decreases with the number of cycles. As we can see here in this graph that fecundability means decrease from 25 to 30% in the first 3 cycles to about 10 to 15% after several months of trial. Infertility evaluation is indicated for couples who seek help because they have not been able to conceive. We initiate evaluation after 12 months of unprotected and frequent intercourse in women under the age of 35 years without risk factor of infertility. But if the woman is between 35 and 40 years, then initiation of evaluation will be after 6 months of unprotected intercourse. We initiate evaluation immediately upon presentation despite less than 6 months of relation in women over age of 40 years, in women with oligomenorrhea, amenorrhea, in women with a history of chemotherapy, radiation therapy, or advanced stage endometriosis. Women with known or suspected uterine or tubal disease. Women whose male partner has a history of groin or testicular surgery, adult mumps, impotence, or other sexual dysfunction, chemotherapy and or radiation, or a history of subfertility with another partner. Who should perform the infertility evaluation? Usually, any practitioner who has a special interest in infertility can start the evaluation. But obstetrician and gynecologists are mainly involved. Also, infertility specialists and reproductive endocrinologists. Female factor alone constitutes 37% of the infertility cases. Male factors 8%, and male and female factor combined 35%. Unexplained infertility is found in 5%, and during evaluation, usually about 15% they get pregnant spontaneously. Male factor infertility usually is divided to 4 categories, endocrine and systemic disorders in 2 to 5%, primary testicular defect in spermatogenesis, about 65 to 80% of the case. Usually the majority of them are dys-spermatogenesis. Sperm transfer disorders around 5%, and idiopathic male infertility in 10 to 20%. Female risk factors may include ovulation disorder in 31%, ovulation disorder in 31%, endometriosis in 18%, pelvic adhesions in 15%, tubal blockage 13%, Other tubal abnormalities, 14%, and hyperprolactinemia in 9%. With advancing female age, there is an increase in the percentage of women with age-related infertility. There is also increase in leiomyomas, tubal disease, and endometriosis. On the other hand, a reduction in coital frequency may occur. Risk factors of female infertility can be divided also to several categories: ovarian with ovulatory disorders, ovarian cyst, ovarian endometriosis or endometrioma. Tubal can be pelvic inflammatory disease, endometriosis, adhesions from previous surgery, hydrosalpinx, and tuberculosis. Uterine factors may include submucous fibroids, Mullerian anomalies, intrauterine adhesions or synechia, polyps, and luteal phase defect. Cervical and vaginal causes include congenital malformation, trauma to the cervix from previous surgery, cervical stenosis, vaginal septum. Other factors may include ovarian age, male factor like varicocele, poor coital technique, and toxins and genetic causes. Ovulatory dysfunction, a lot of causes can lead to anovulation, but central causes are important due to intense exercise, eating disorders, stress, hyperprolactinemia, lactational amenorrhea, pituitary adenoma, Kalman syndrome, tumors, Sheehan syndrome, empty cell syndrome. Other disorders include polycystic ovary, hyperthyroidism, hypothyroidism, hormone-producing tumors, chronic liver and renal diseases, Cushing disease, congenital adrenal hyperplasia, and many other cases. Medications also can cause ovulation dysfunction, like estrogen, progestin, contraceptives, or progestin alone, antidepressant, antipsychotic drugs, corticosteroids, and chemotherapeutic agents. World Health Organization classification of anovulation divided anovulation to 3 classes. Class 1, they call it hypogonadotrophic, hypogonadal anovulation. It's hypothalamic amenorrhea. Here, FSH is low with low estrogen or estradiol, while in normogonadotropic, normoestrogenic anovulation, FSH and estradiol are normal, as in polycystic ovary. And in class 3, hypergonadotropic, hypoestrogenic, here the FSH is high, while estradiol is low, as in premature ovarian failure. Also, the 4th category of anovulation is hyperprolactinemia, which inhibit gonadotropins and lead to low estrogen. Genetic causes of infertility are common, especially karyotype abnormalities like trisomies, mosaics, translocations. In females, the most common aneuploidies is 45X, while in male, 47XXY, Klinefelter syndrome. There are emotional and educational needs during infertility evaluation. We should always deal with disease, with infertility as disease of couple, not as individuals. And we have to deal with the feeling of guilt, with the feeling of frustration and anger with the patient as infertile patient. Usually, always they think it is a punishment or something for them for the sins which they did. That's why they are not getting babies. So this feeling of guilt or anger or frustration, we should deal with it and target it in a proper way. Otherwise, our management is incomplete. Also, the patient asks where to go for information. We have to help her and guide her. Also, she may ask, what are my options at these situations? And here also we should tell her what is her option according to her circumstances. There are support groups like Resolve. Resolve is a support group, can help the ladies to target their problem with the other ladies and find a solution for herself. When we evaluate, usually we target organ by organ, like ovary in a female, ovary, tube, corpus, etc. In male, we do semen analysis and we look to the ejaculate characteristics and anatomical anomalies in male. The most important factor in the evaluation of infertile couple is history. During history taking, there are general information can be taken from both couples. Both couples should be present during interview, and the age of both couples should be taken. Previous pregnancy by each partner is taken also, and the length of time without pregnancy. We took sexual history, frequency and timing of intercourse, the use of lubricants, impotence, and on anorgasmia and dyspareunia. We use also to take contraceptive history. It's important. Regarding male history, it's important to search for pelvic infections, radiation exposure, toxic exposure, including drugs, and history of mumps in the male, and testicular surgery or injury to the testicles. Also, excessive heat exposure or spermicidal exposure. For female history, we search for previous female pelvic surgery, pelvic inflammatory disease, appendicitis, use of intrauterine contraceptive device, ectopic pregnancy history, and history of endometriosis, irregular menses, amenorrhea. We should take detailed menstrual history from the patient. And also we look to the vasomotor symptoms as indication of premature ovarian failure. We look to the stress in with the patient, and we search for any weight change and any heavy exercise practiced in the past. Also, we look to the cervical and uterine surgery. On physical examination, we search in the male, we search for the size of testicles, testicular descent, presence or absence of varicocele, and outflow abnormalities like hypospadias. While in female, we search for thyroid problems, pelvic masses, uterosacral nodularities, abdominopelvic tenderness, uterine enlargement, uterine mobility, and cervical abnormalities. Always, we should take a break and reevaluate the situation of the patient. And for this reason, also, I will let you take a break and look to this. Life is hope is my drawing or painting during Corona time. And this is related to our topic. As we can see, this infertile couple looking to a baby in the sky, and they are attached with a heavy chain to the infertile land and infertile tree, and with hope, with patience, and with our support, they will break the chain and come to the fertile land. And this one was done last 2-3 months ago. Assessment of ovarian function usually start with documentation of ovulation, taking basal body temperature. Of course, we don't need to go through all this because basal body temperature is difficult, and usually some patients, they like to do it, but for me, I depend always on ultrasound for evaluation of ovulation. But all this can be also used for detection of ovulation. If premature ovarian failure is suspected, then we perform FSH. But TSH and prolactin and adrenal function also are indicated in some situation. The only convincing proof of ovulation is pregnancy. As we mentioned before, the three main types of ovarian dysfunction are central hypogonadotropic hypoestrogenic, or polycystic ovary normogonadotropic normoestrogenic, or premature ovarian failure hypergonadotrophic hypoestrogenic. Assessment of tubal patency, usually we use simple way is hysterosalpingogram, but hycosi can be used also for assessment of the tubes, but also laparoscopy is also used for infertility situation when we have suspicion of other pelvic problems like endometriosis or adhesions. Laparoscopy is invasive and require operation theater, can offer diagnosis and treatment in one setting, and not necessary in all patients. It can be used for lysis of adhesions, diagnosis and excision of endometriosis, myomectomy, and even tubal reconstructive surgery. Asherman syndrome is diagnosed by hysterosalpingogram or hysteroscopy. Usually is, we have history of dilatation and curettage or myomectomy or other intrauterine surgery. It's associated with hypomenorrhea or amenorrhea and recurrent miscarriage. Fibroids and uterine anomalies rarely associated with infertility, but the workup include ultrasound, hysteroscopy, and laparoscopy. The cervix is assessed by culture if we have cervical erosions or evidence of infection in the cervical assessment. We can do also postcoital testing. Usually in postcoital test, we look to the quality and quantity of the cervical mucus, and we found that the quantity is very subjective, but the quality should be stretchable more than 8 centimeters, and it should be clear and showing on microscopic examination the turning or branching module of the crystallization of the crystals of the mucus. Viscosity should be very thin, and there should be no white cells in the cervical mucus on microscopic examination. Also, there should be progressive motile sperm more than 5 to 10 per high power field, and on gross sperm morphology should be within normal. Regarding endometriosis, it is associated with doubling the relative risk of infertility. It is diagnosed and even treated by laparoscopy. It can be familial and can occur in adolescents. Etiology is unknown, but it likely multiple one, like retrograde menstruation, immunologic factor, or genetic factors. Medical option remains suboptimal. Regarding male factors, we test for serum testosterone, FSH, and prolactin level. We do semen analysis, and we do scrotal ultrasound. In some cases, we do testicular biopsy and even sperm penetration assay. In semen analysis, usually we collected after 48 hours of abstinence. It should be evaluated within 1 hour of ejaculation, and if abnormal parameters, it should be repeated in 2 weeks time. Normal semen analysis include volume more than 1.5 ml. Sperm concentration should be more than 15 million. Total sperm number more than 39 million. And per ejaculate, and morphology more than 4% should be normal, and vitality more than 58% live. Progressive motility in more than 32%, and total progressive and non-progressive motility 40%. This is according to WHO. What are the treatment options? Usually, ovarian disorders can be divided to these categories. So we can say for anovulation, we use clomiphene citrate and human chorionic gonadotropin, or human menopausal gonadotropin, or induction plus intrauterine insemination. And if high prolactin, we use Dostinex, bromocriptine, or sometimes in macroadenoma present. If macroadenoma present, we use transsphenoidal surgery. For premature ovarian failure, we don't have too much to do, but high dose of human menopausal gonadotropin can be tried. Central amenorrhea, usually we use at the beginning clomiphene citrate, then human menopausal gonadotropin, and at the end we can use also pulsatile gonadotropin releasing hormone. Luteal phase defect, we use usually progesterone support or dydrogesterone, or we can use clomiphene citrate with HCG. Ovulation induction with clomiphene citrate, usually we induce ovulation in 70% of the cases, but the pregnancy rate is only 40%, compared to 60 to 80% in human menopausal gonadotropin. Usually we start on cycle day 3 or 5, and multifetal rate is 5 to 10%, while it is 10 to 15%, even little higher in HMG group. What are the risks of this clomiphene citrate compared to human menopausal gonadotropin? Usually they are, with clomiphene, they are very simple. Sometimes some vasomotor symptoms or headache and multiple gestation, while in HMG, multiple gestation is common. Ovarian hyperstimulation is one of the major problems when we stimulate ovulation with human menopausal gonadotropin, and sometimes can be fatal if untreated in intensive care unit. Fallopian tube problems can be managed with tuboplasty, but actually IVF is the best practice in the current days. Uterine corpus, for Asherman syndrome, we use hysteroscopic lysis of adhesions or postoperative antibiotics, plus postoperative antibiotics and estradiol. Rarely, for fibroid, we need a treatment. Myomectomy, hysteroscopic or laparoscopic or open, can be done. Uterine artery embolization is not used for infertility situations because it may affect the ovaries. Uterine anomalies rarely need treatment, and metroplastic is one of the alternatives. If we have cervicitis, we use antibiotics. If scant mucus in the cervix, we use low-dose estrogen, and sperm motility issues, anti-sperm antibodies can be used, can be treated by steroids or intrauterine insemination. For endometriosis, excision is better than medical treatment. Laparoscopic lysis of adhesions may help, but invasive and expensive. Gonadotropin releasing hormone analogs, not a cure, and has a side effect and expense. Danazol has side effect and cost. Continuous oral contraceptive pills leading to poor fertility rates. The chances of pregnancy are high within 6 to 1 year after 6 months and 1 to 1 year after treatment. Regarding male factors, hypogonadotrophism usually is treated by human menopausal gonadotropin or gonadotropin releasing hormone, and sometimes treated with clomiphene citrate plus HCG with poor result. Varicocele can be treated with ligation, but no definitive result till now. Some people, they support its use, regular use. Some people, they said wait and do medical management. Retrograde ejaculation is also a problem for male infertility. Can be treated by ephedrine and imipramine, Also, artificial insemination husband can be used with recovered sperm. Idiopathic oligospermia, there is no effective treatment till now. IVF is one of the alternatives. Donor insemination is not an option in Islamic or religious people. Unexplained infertility occur in 5 to 10% of couples. We consider testing for prolactin, doing laparoscopy, other hormonal testing, cultures, anti-sperm antibody testing, sperm penetration assay if not done. We review also previous tests for validity. There are some empirical treatment for unexplained infertility like ovulation induction, antibiotics, IUI, and we consider IVF and its variant if no treatment, no benefit. Adoption is one of the alternatives. In summary, infertility is a common problem. It is a disease of couples. Evaluation must be thorough but individualized. Treatment is available, including IVF, but can be expensive, invasive, and of limited efficacy in some cases. Consultation with a reproductive endocrinologist is advisable. Thank you very much for your listening.